we can diagnose type 4 supracondylar, Gartland IV supracondylar fractures before going to the OR. And this is something that I realized some years ago, but I tried to publish the paper I published a couple of years ago, but I tried to publish. It was hard because nobody believed or understand this. But every time I had one of those X-rays, I am more convinced that I am right about that. So this is the paper. I will put the paper here in the chat. This here you will find all the information, and you know that the classical dogma is or statement is that multi-directional and stable supracondylar fractures are only diagnosed intraoperatively. These are the first three papers. The first one is from Leitch, and then appear some other papers with bigger numbers. It's an uncommon. It's 1-2% of all supracondylar fractures, so you don't see many of them. And this is what shocked me. No? So this is a type 3 Gartland fracture, right? You have a complete cortical disruption, right? But the distal fragment is pretty well misaligned or separated, right? This is a Gartland 3. But then it came in 2008 that I got a fracture like this. What shocked me? It shocked me that, of course, all cortices are disrupted, but if you look at the lateral view, the distal and the proximal fragments are pretty well aligned. And this is shocking if you have a complete bone disruption, right? So in that case, I saw that it was a Gartland IV, and then I checked. I had this idea, and I checked for many years these fractures. This is another one. It was a Gartland IV. If you look at the lateral view, the fragments are pretty well aligned. Another one. This is displaced in varus. And this is what you see the OR. Inflection, if you flex the elbow, you flex the fragment, so you cannot stabilize the fracture with elbow flexion, right? And I check the other papers, and you check the late paper, and what you have, the same pattern. So complete cortical disruption, but pretty well aligned in the lateral view. And you check this recent paper with with I don't know 20-30 cases, the same pattern. And again this. So in my paper, I published 13 patients in a 7 years span period, and I analyzed the maneuvers for reduction. Of course, all of them reduce in semiflexion because it's a multi-directional instability, and some of them reduce in pronation or supination. So I saw two patterns: valgus displacement that reduced in supination and semiflexion, and varus displaced that reduced in pronation and semiflexion. And here came the idea. The idea is that this is a coronal injury. So there is a periosteal hinge in one of the sides. If it's in valgus, the periosteal hinge is lateral. If it's in varus, the periosteal hinge is medial. Okay, So then when you try to reduce, you reduce in semiflexion, of course, and this is a valgus injury, so in supination. Okay, and why? Because there is a lateral periosteal hinge. So these are injuries in vargus or valgus. These are not extension injuries. These are coronal injuries. And this is my I'm really bad drawing, but this is my draw. So in varus you have a periosteal hinge, so there is a disruption, a hemicircular disruption of the other side of the periosteum. And if it's in valgus, it is the medial periosteum that is ruptured hemicircularly. Okay. Again, varus injury, medial periosteal hinge, pronation reduction. Valgus injury, lateral periosteal hinge, supination reduction. Okay, and then I check these recent papers and that assess for factors or characteristics that are more typical of Gartland IV fractures. These are statistical papers, but they say the same. If you have flexion angulation, there is a bigger risk that you have a Gartland IV. If you have valgus angulation, also. If you have lateral translation, if the fragments are aligned, so they are saying the same as me. But also here, if you have varus or varus angulation, bone apposition, medial translation, so they are saying the same as I'm saying. The same. Okay, so yeah. So these are the conclusions. If you have this pattern of a complete cortical disruption, but in the lateral view, it's pretty well aligned, probably it's a Gartland IV, and you have to reduce in semiflexion and pronation or supination. Okay, and this is the last case. Some weeks ago with my colleague, we saw this fracture, and I said, this is a Gartland IV. And she said, how you do know? Okay, let's go to the OR. But this is the reality. So you have these X-rays, you don't have an AP and a lateral view, you have an almost AP, almost lateral. Okay, this is the reality. So we went to the OR, and first, you see in this picture, you see this ecchymosis, medial. Why medial? Because this is because this is a coronal injury. Okay, again, and then you see how in the lateral view, the fragment is very well aligned. And if you try to reduce inflection, as usual, as with like a Gartland III, you get a flexion of the distal fragment. So you have to reduce it in semiflexion. You have to find what degree of flexion is the best. And then you check, you can see how it is a Gartland IV, okay, multidirectional. What is called multidirectional? I think we should call it a coronal supracondylar fractures. Okay, and this is how it reduced pronation and semiflexion. See? And you have to find the better reduction. So the reality is that it's really hard because it's unstable, but it's really hard to reduce. And because it's really hard, because it's unstable, you put first a wire in the distal fragment. Then you reduce, and then you place the wire, and you don't have to look for radiographic cosmesis because it's very unstable. You don't have to look for the perfect placement of the wires because it's complex and stable. You will end opening the fracture, and it's not necessary. So we put put the wire in the distal fragment, reduce, you advance the wire, you are happy because you took the cortis, and then you put another wire and you have this. You think that there is some rotational displacement, but it's not. It's because there is still some medial translation, okay? And then you put one more wire, you have a cosmetically ugly radiographic result, but a nice clinical result for a complex fracture. And that's all. Many thanks.
Paco, super interesting, actually. Can you hear me, Paco?
Yes, yes,
okay.
Yes.
So let me start the questions. I have a couple questions. So number one, the fact that you realize it's a coronal fracture, has it decreased the number of times that you've had to open
it? Yes, I think I never opened a Gartland IV. Yes.
Yeah, I agree.
I've opened Gartland III several times, but not a Gartland IV.
I mean, I agree they're so difficult because you can't get control, but maybe we've been looking in the wrong plane. And Paco, take me through it one more time. So if in the coronal, if it's posterior lateral, right? You're saying that the lateral periosteum is intact. Is that correct?
So if they are lateral, also valgus.
Valgus, yeah.
They are in valgus. You have the lateral periosteal hinge.
And that reduces in supination or pronation?
Supination.
Supination, and then vice versa for varus.
See, the same. It's the same as in Garland III, when
Yep.
you have medial or lateral translation. See.
Yeah.
But the periosteum is the situation of the periosteum is different.
Yes. Right, because the anterior posterior periosteum is disrupted, is what you're saying.
Yes, yes, hemicircularly disrupted. Yes.
Yeah. Paco, there's a question. Do you use external fixations for some complicated supracondylar fractures? Have you ever used external fixator?
I don't have experience with that.
Yeah. Yeah, I don't either. I think the other thing that Paco showed that's important to just emphasize is we have this expression, it's big pins for big people and big pins for little people. And if you notice, I don't know what size pins they were, Paco, but they were big pins. They look like 2 millimeters. Yeah.
That's what you taught me.
Yeah. I mean, they have to be big pins. You know, I have to give you kudos, Paco. I've never really thought of Gartland IV as a coronal fracture, but I will from now going forward, right? And the other question, which I think everyone's thinking, is in that case that you showed, the more recent case, did you contemplate using a medial pin for that fracture or for any type 4? Do you ever use a medial pin?
Yeah, I try to use lateral pins. But so in general, I put the 3 lateral pins. I put one close to the. So we are talking in general, not in this type of fracture, because in this type of fracture, everything is that unstable that you do the better you can, no? But in general, I put one wire close to the olecranon, the other wire as much as separated as possible, and then once you have 2 separated wires, you put one in the middle because it's like they are asking for you to put three lateral. So and then I check the stability. If it's unstable, I put a medial one, but it's rare. So in general, I try lateral pins are enough. 3 lateral pins are enough.
And Paco, Mohammed asked, have you ever used a transolecranon pin in highly unstable supracondylar fractures? Right through right up the pike.
Never.
Yeah, I don't have any experience. Does anybody have any experience with the transolecranon pin? I don't either, actually. Yeah. I'm not afraid to put in a medial pin either. I think a medial pin helps. You can do 2 or 3 lateral divergent pinning, but then you have to try something else. Just remember, everyone knows this, when you put in your medial pin, make sure your ulnar nerve is out of harm's way and your elbow's not too flexed, because you'll bring ulnar nerve right into the picture. We just saw a case where they got the ulnar nerve from a supracondylar fracture, which is a bad complication. More questions? More? Amro, you have any thoughts for Paco while we're chatting?
Yes. I'm asking about in valgus and varus, we have a complete disruption of another site. If you have a valgus injury, you have a complete cutting or injury of periosteum on the another side. So, and I have some cases I should to open to remove the periosteum inside the fracture site, because it's so difficult to reduce. It may be happen in some cases. So in some cases, I do an open reduction. It's amazing and very difficult to do to get reduction closed in some cases.
Yeah,
So
it's a
maybe
good
happen. It maybe happen. Yeah.
Yeah, it's a good question, Paco. Do you ever see the disrupted periosteum interposed that prohibits reduction? I think that's what Amro's saying, right? So if you had a valgus, does the medial periosteum ever get interposed where you have to pull it out?
So for a Gartland IV, I've never opened, so I don't know. For Gartland III, is muscle what is interposed, no?
The brachialis.
Brachialis muscles. Yes.
And Paco, you just open it through an anterior approach. That's your standard approach, if I remember.
Yes.
Yeah, just a transverse incision, correct? Because you come right down on it.
Yes.
Yeah.
So in supracondylar, what you are really doing is you are not really reducing the fracture. You are taking, because you are not looking for a perfect reduction. You are just like taking soft tissue in the fracture, and just you touch with the fingers, but you are not really looking for a perfect reduction in the supracondylar.
Yeah. I just got to say, get Emma.
You are lucky because you are the first doctor to touch the patient. But here in Egypt, maybe I see the patient after 2 or 3 reduction before me. So maybe I need to open the patient and reduce.
Yeah, of course. We will never have enough experience because they are not common.
You mean Gartland IVs? That's correct. Yeah. For us, the only time I ever notice it is when we go try to reduce it and it goes into flexion. And then I'm like, okay, we're going to be here for a while now, right? Because all of a sudden your supracondylar fracture, which is not going to take you long, is going to take you long. But I maybe it's not going to take me as long now if I tried supination and pronation rather than continue to flex and extend. I'm going to give it a go. I think it was a great talk. Thank you very much.
Thank you, Scott.